All the learners, I had attached the pretest link, so I request you all to fill the same.
Yes, good afternoon, ladies and gentlemen. Can you hear me? Hello. Can anybody confirm, please? Hello. Hello. Can anybody please confirm that am I audible? Hello. Yes. Good afternoon, everyone. Once again, I'm Bipin. Today we will talk about information technology in healthcare. This is the your Block 2 information technology in health, and your module is 019 emerging issue in healthcare management. So yesterday we have gone through the different aspects of ABDM and DHM and the overall digital health maturity that start with the W Health, WHO. They provide us the global strategy and then we refine it for our national use. As India, we are still lower middle income group country. So we adjust our digital health strategy accordingly. But as India, even we are a developing country, but we have mastered two things. The first is the software development, and the second is the IT infrastructure. We should take proud of India that even with the status in the global arena that we are a lower middle income group country, but that we have achieved so far full-fledged digital maturity. Just let me give you example. 99% of our population are now under at least 4G mobile cover and has a good amount of computer and digital literacy among the young people. So in the Block 2, we will review the our course structure to start with. So it consists of a unit from 6 to 9. Unit 6, we will review the area called as clinical informatics and patient outcome improvement. In Unit 7, we will cover once again, we yesterday talked about the telemedicine, remote care, and virtual consultations. In emerging technology in digital health, what are the various emerging technologies that we are bringing in the digital health domain. And in Unit 9, we will cover how we design and develop and implement and evaluate and audit of the different kind of digital health applications. So now let's start with the clinical informatics. So in the clinical informatics, you see it's it's a new domain, it's an emerging domain. It has a two components basically. One is the clinical domain. Uh, so it has a two components. One is the clinical side of it, and one is the informatics side of it. But if you see the combined term, that's clinical informatics, is to deal with lots of day-to-day clinical management, disease management, drug management, hospital unit management, and population management. So in clinical area, it actually cover everything. Start with medicine, surgery, ophthalmology, gynecology, obstetric, and in informatics side, it is a combination of three sciences. The first is the computer science, second is the information science, and third is the management science. So informatics is a combination of three sciences and helping the clinicians or a clinical knowledge to evolve and flourish to improve patient's clinical outcome and improving the management of the patient while patients are either in their home or in the hospital or they are getting treated for any clinical conditions. Are you able to see my next slide? The clinical informatics that's defined.
Yes, sir.
Yes, sir.
Okay. Yeah, thank you, Dipti. So here, in this slide, which is I have combined from the your module itself. So nothing actually is outside of your curriculum. So it's, I just mentioned about it is interdisciplinary science. It's very interesting. It's right now it's evolving rapidly among all the European countries, Americas, and even in India. Right now, the number of clinical informatics professionals are now in high demand. So here you see through the clinical informatics lens, what we elaborate. One is the information technology, which we are using in day to day in and day out. One is the data system, and one is the patient care and healthcare delivery. So we are combining those all disciplines in clinical informatics. So I just mentioned it's to deal with the medicine, computer science, and data, and it's now recognized medical specialty since 2011. In USA, that you can pursue master's degree in clinical informatics. So now, in the applied clinical informatics, we improve our day-to-day clinical task efficiency and effectiveness. So as a hospital administrator, you will deal with the medical faculty, you deal with the computer science people, you will deal with the data science, and you will deal with the artificial intelligence specialist working along with you to improve the clinical outcome of your patients. In this slide, why informatics? Why we need informatics as a science, as a discipline in our hospital. So three main objectives, it is in front of you. As a hospital administrator, as a hospital manager, your objective is to improve and maintain patient safety. Use healthcare and clinical and administrative data for your day-to-day decisions. And the last but not least, it's a connectivity. Connectivity, we are not talking about the connectivity of the phone line or a 4G tower. We here mean of connectivity that patient's record is accessible for all who require the patient's related information at a point of care. So we are connecting all the patient's details as a dots as a point of care information. So clinical informatics make it possible to give all the information whilst you are looking after the patient. Either patient is in operation theater, patient is on outpatient, patient is on any diagnostic process or a procedure. We need to maintain the clinical informatics in action to achieve patient safety, decision making, which is data driven, and to connect all the dots about the patient care. So now you see the line below it, transforming raw clinical data into valuable insight for treatment optimization. So optimization is the key here by using the clinical data for the patient. So now let's talk about the two major concepts here. First is called as a EMR, means electronic medical records. Second is EHR, electronic health record in an Indian context. Most of the EHR and EMR in India is actually confusing because there are clear-cut features that actually differentiate EHR and EMR. So here you see, many times you have heard about the electronic medical record. Many times someone is just mentioning that we are using EHR. Someone even mentioning about that we are not using EMR, we are using HIS, Hospital Information System. Someone you come across that is mentioning about the Health Information Management System. But combining together each and every solution is actually to deal with the patient. Okay. Invariably, the design of that particular solution is specifically designed for some aspect of the patient. So here you see the feature scope sharing and Indian standard, which is how we can differentiate electronic medical record and electronic health record. So you might come across question from your hospital executive, maybe you yourself evaluating the electronic medical record or electronic health record. in your future job, you need to ask the following question. Scope, sharing, and what are the Indian standards this EHR or EMR is following? Okay. So here you see EHR, it's a longitudinal record. So you need to remember this word. EHR is always the combination of the few EMR record which is used. May I ask audience to
वो खाए
use
थे आपके
the
करेले मैं कभी नहीं खाता हूँ लेकिन बहुत अच्छे बने थे टेस्ट कर मैंने हाथ नहीं धो रखे हैं मैंने जाती हूँ ते धो के आ जा
hello? May I ask to just
मैं
mute
आलू
your
मैं टेस्ट करूंगी
yeah, thank you, Priyanka. So here a longitudinal record is an important factor to decide whether the solution is EHR or EMR. Okay. The other aspect of EHR that you see is it's interoperable across the multiple facilities. So let's see Apollo, Max Healthcare, or the Fortis Healthcare. Okay, they have a 15 to 20 hospitals across India. But through the EHR, they are able to connect all those facilities across India. So let's say you visited Delhi, Fortis, okay, and you have a radiology and laboratory result pending there. And now you have visited Fortis facility in Mumbai, very next day. And doctor wanted to see that particular radiology and laboratory result of yourself in their hospital. But due to the feature of interoperable across the multiple facilities, the doctor can access the blood result or a radiology report from the Fortis side, from the Delhi to the Mumbai side. So let's see this the use case of electronic health record. So you see, there is a combination of multiple things that is available in your cloud-based EHR. You need to remember this terminology. So EHR has a main two versions while it's working in the hospital. One EHR is exclusively designed and deployed in a local server. Okay, so you can't export any data outside of that particular hospital facility. So your computer terminal and your server, it is in the same hospital building. You can't export anything out of that hospital. And that is called as a client server architecture. But as we go along with the maturity of digital health system, with the maturity of EHR, now most of the EHR available in India, it's cloud-based. So the two server of the two different hospital sites actually connected with the internet where they can share all the data. So hospital A can send the information to hospital B if they are agree to connect and share their data. So what's the benefit? What exactly the cloud-based EHR helping us to do? So you can send real-time patient data. So let's see if your radiologist is not available in facility A and one radiologist available in facility B, you can send X-ray film directly to his computer to review it. The another excellent facility the cloud-based EHR providers, it's integration with the mobile and wearable device. Many advanced hospitals in India or in foreign country, they use the wearable device. Let's say blood pressure monitoring or a diabetic monitoring. That data automatically gets fed into the your EHR system. So you don't need to repeat anything to your doctor. They already can see your data as it getting fed into the your EHR. The another interesting factor about the cloud-based EHR that it integrates and talks to your mobile. Many of you have noticed that nowadays most of the hospital has their mobile application, and most of the hospitals now allow you to book doctor's appointment through the mobile itself. So it is an excellent example of replicating railway ticket booking and the bus ticket booking, that you are actually booking your slot with the doctors. You don't have to ring the secretary. You don't have to ring anyone else. You just access in your mobile and you book your appointment with the doctor. Now, in a recent time, I have noticed many hospitals have provided patient, it is called as a patient portal. So patient portal, how does it work? So patient use their Aadhaar ID or their email or a WhatsApp number to gain access to hospital's portal, and they can review their medical record, they can review the doctor appointment, they can review their dietitian instruction for their disease management. And another important aspect of cloud-based EHR is analytics for predictive insight and early detection of chronic conditions. So here we are talking about the analytics of your patient's data, which allow doctor to predict something if your disease condition is improving or not. It is getting deteriorate or not. So through the means of connected data, connected application, connected doctor and connected patient, nowadays we are able to manage chronic disease condition effectively, because now your doctors know if something getting deteriorated in your blood, in your urine, or any of your habits. Are you able to see my next slide, hospital information system?
Yes, sir.
Yes, sir.
Yes, thank you. So in the information system, I just in the previous slide, I have mentioned that you will come across a lots of names like EHR, EMR, and here that hospital information system. So what is hospital information system? It is the digital backbone of the whole hospital. It has nothing to do with the department. It has nothing to do with one patient. It has nothing to do with one doctor. It has to do with the whole hospital getting digitized. Okay. So now we have to combine all the department in the hospital to talk to each other, to coordinate with each other, with sharing of the detail about the doctor, about the patient, about the laboratory, about the billing. Everything is combined in the concept called as a hospital information system. Okay, so now you see on the right side, you'll see the LIS, RIS, pharmacy, and billing. We have achieved something even many developed nations hasn't achieved. It is called as a ABDM compliance for to create the unique and unified Indian healthcare ecosystem. All records, which is, let's see, we have created laboratory information management system, billing, it actually getting saved in your ABA ID. So even many advanced countries not managed to achieve that what we have achieved through the ABA ID and connecting the all the hospital information systems details in cloud, which is secured by your mobile and your OTP. In earlier slide, I mentioned about clinical informatics. CDSS, it's becoming the important tools for the doctors, for the nurses, for the physiotherapists, for the pharmacists. So what exactly is a CDSS? May I ask in the chat how many doctors are here? If, if you have a rough number, how many doctors are attending this lecture? Yeah, so I can see it's Jenica, she's a doctor. Who else? Raghav, yeah, you are a dentist. Good. So you as a doctor, what basis you are taking your day-to-day clinical decision? If someone just tell me how they process the information and how they make clinical decisions. Anyone?
Sir, as I am working with a college, there is a healthcare system software which is called Orion. So on the day-to-day basis, we track down the history of the patients and give a specific ID to each and every patients. And if the patient comes again, we can track down all the case history of the patients and data stuffs and the payment also.
Oh, okay, Dr. Raghav. Anyone else? Yeah. Okay, thank you. So basically, in advent of the generative AI technologies, and lots of other computer science that let's give you example, multimodal. It's actually working for us directly or indirectly. So any computer application, any information science application, or maybe any algorithm which is work for us, it's called as a decision support system. So you don't have to go into that technical detail as you are a management student, but what I would like you to understand, to explore and elaborate the various applications for the decision support system. And here we are elaborating CDSS. It is called as a clinical decision support system. Okay. It is not computer, but it's a clinical. So here, what I try to elaborate, what I would like to learn, it's to start using the different CDSS tools available in the market. Have you heard about the up-to-date? It is the excellent tools available in your Android or iOS phone. So I would like you to test it. It gives you the intelligent support if you are stuck with any medicine, if you are stuck with any symptom or sign of the patient, and you would like to make a tentative diagnosis out of the patient's information, you can fit into it and it gives you the possible 3 or 5 most accurate diagnosis. Okay. So what technology working behind it? One is called as a rule-based, second is AI-based, and third is a predictive. So in the rule-based, how it exactly works? It's a if and then logic. So nothing too much technical. So let's see, patient comes to you and they tell you that I'm allergic to sulfa drugs. Okay. So as a doctor, patient is now allergic to sulfa, so you don't prescribe the sulfa drug to the patient. That is called as a rule-based. But how computer know how rule works? So it creates the logic between the prescription and it will create the logic between the allergy. Okay, so allergy pill, you put sulfa drugs, it automatically dictate the rule to the doctor, not allowing him or her to prescribe the sulfa group of drugs. So that is called as a rule-based clinical decision support system. Second, AI-based. So basically, it's thinking for you. Okay, it's emulate your intelligence capability that you actually gain from the 5 years and 8 years of medical journey. And predictive, it actually statistical simulate the prediction, what exactly can happen after 5 days, 7 days. So let's say you have a mild pneumonia. Okay. If it is 25-year-old gentleman, young, fit guy, the pneumonia won't get deteriorated. But if patient's age is 85, patient is with COPD, patient is with asthma, if you put diagnosis as a pneumonia, it can predict the severe pneumonia because now you have an added predictive intelligence to put COPD and asthma, which is obviously you can predict, okay, patient is going to get deteriorated. So that is rule-based, AI-based, and predictive modeling of your clinical decision support system. This is one of the aspects that we are lacking in Indian healthcare system. I have worked in many advanced countries. What I have noticed, they have clear-cut clinical pathways drawn for the doctors, drawn for the hospital, drawn for the patient group, and drawn for the particular patients. So each and every patient come into the journey in the hospital. They have a predicted steps and stages to go through in their entire journey of the treatment. So what are the benefits of the have a standardized clinical pathway? So when you become a hospital manager, if you become a quality manager in the hospital, I strongly recommend to use this concept in your hospital. You will here is the three key benefits are listed. The first is improved collaboration across the team. So surgeon know what he is doing, nurse knows what he is doing, clinicians, physiotherapists know what he is doing. So they are in the same page. They know what exactly is happening with the patient. The next is reduced unnecessary duplicate tests. And the third is the scientifically backed recovery timeline. So you know when patient is going to get recovered and discharged from the hospital. So you have a predicted step and stage identified for the each patient. So let's see here the example given here. Knee replacement, day 1, day 2, day 5, what's going to happen? Okay, so you have a now structured plan. So if one doctor come on the day 3 and he is now viewing the patient first time, but due to the standardized clinical pathways, he or she should be able to see that patient on day 3 are going to have a physiotherapy and mobility check. So they don't have to ask anyone else. They know what exactly is going to happen on the day 3. That is called as a standardized clinical pathways. So here's the more component of clinical pathway. So you see it has a component, diagnosis, step in the care, timeline, who are the responsible for that particular task of the patient, and what exactly we are expecting from that intervention. This is very important. So if we are targeting patient to be discharged on day 5, everyone know that it must be achieved because this is the expected outcome. That's what we are doing. Okay. Each surgery, each medical intervention has a certain timeline. Like patient to stay 3 days, patient to stay 5 days, patient to stay 24 hours, and so on. So you have a now, due to the component of clinical pathway, the understanding and agreed clinical pathway allows you to design your hospital services and your resources you need for the day-to-day plan. So when you become a hospital or healthcare manager anywhere in the big hospital, your objective is to utilize the resources effectively. And the clinical pathway allows you to learn and to manage resources available to you. One question for audience. Have you used any type of dashboard in your life? Anyone from the audience, please? Our
Sir,
next.
Power BI.
Yes, thank you, Dr. Raghav. Excellent. Power BI. So what the Power BI is? What exactly is a tool?
Sir, it collaboratively represents all the data which we are going through and show it in the graphical form.
Okay, fantastic. Anyone else? Has anybody used any type of dashboards? You are using while you are driving your car. That's the dashboard, isn't it? So in the dashboard, why you need dashboard in the healthcare? We have nothing to do with the dashboard. This is data, this is graph, this is why. as a hospital and healthcare managers, why we need dashboard? Anyone, please. If I don't provide a dashboard, what does it make different to your day-to-day function?
Sir, it presents so for information for about revenue, expenses, staff attendance, all that recorded in the same place.
Okay. Very imperative for any hospital. The dashboard guide day to day, week to week, month, and quarterly planned activity, which guides you what to do, how to do, when to do, and where to do. So it gives you the intelligent support to make quick and effective decision, and which is coming from your data itself. So you never can go wrong because it's this dashboard is created from the data collected from across the hospital environment. So here we are talking about the three main dashboards. It's a very interesting subject. You can explore more. But here, what we need to learn from that particular curriculum, that is three dashboard: clinical dashboard, operational dashboard, and a financial dashboard. Okay. So you are a hospital manager, you go to your cabin, your office, you will ask doctors to see their clinical dashboard. You will ask the chief operating officer to review the operational dashboard, which is about occupancy and staff ratios for the particular day and particular week. And when you meet CEO or CFO with some report, they won't ask about the clinical dashboard. They will ask about the financial statement of the hospital or a financial information of the hospital, which is billing, insurance, means claims, and the hospital profit margin, which is just Raghav. Power BI, it's combining the data collection plus analytics plus visualization. So, in a nutshell, dashboard, it's the other name given, it's called as a business intelligence. So you can combine three data sets: clinical, operational, and financial, to make it happen to make day-to-day decision in your hospital, irrespective of your size. You have a 100-bed hospital, 200, 1,000 beds. So it's now nearly 45 minutes, so we will take 5 minutes comfort break. We will resume at 17:50. Thank you all. Can you hear me?
Yes, sir.
Yeah, and my next slide visible or not? The essential healthcare KPI. Is it in front of
Visible,
you?
sir.
Yeah, okay, thank you. So now we just learned about the dashboard, but dashboard is always tricky. What you see, you need to interpret it for the practical reason. As a hospital administrator, as a healthcare manager, you are not just dealing with the dashboard, but you are actually understanding the KPI, key performance indicators. So when you see the dashboard, you see the number and the story behind the numbers, and now you need to interpret it to be able to make judgment and decision out from your number. So here is the example. It's a very common example like a bed occupancy rate, readmission rate, maternal mortality rate, and the neonatal mortality rate. Now tell me from this KPI, so if our readmission rate goes up, is it good or bad for us? So what do you interpret? Like our 30-day readmission rate, it's going up. Is that good for the hospital or bad for the hospital?
Sir, bad.
But
Yes, Dipti.
yes, sir, it is bad for the hospital, sir.
Why? You are getting admission.
So because if any problem is there, patient gets the complaint back. So we need to readmit and cross check whether it is cured or not and see it again. Where is the problem and all.
Okay. Yes, Raghav.
Sir, the insurance company pays for the specific period of time. If the insurance is for 15 days, they are not gonna pay for next 30 days.
Yes, that's a good explanation. Yeah. So when we get the patient readmitted, okay, it shows the what sort of quality of our discharge care. So patient is just gone to the home without proper antibiotics, proper care, proper support, proper equipment, proper medicine. Okay. And when this lax approach happen in hospital, we get patient back into the hospital, and that is our 30-day readmission rate. Okay. So now we have to manage this patient once again, and insurance company won't cover that particular number of days that we cover the patient care. Okay, so we lost the revenue, we lost the bed, we lost the patient even. So, yeah, so my advice is for all of you that you understand the story behind the number. Okay, that's important for the healthcare KPI to put your intelligence and expertise to improve the hospital performance. So when you see the numbers, you need to make sure what are this data is, what are the data collection process, who has approved this data collection, and how we calculate the data. Okay. You go more specification of the data collection, you get more intelligence out of your dashboard. So this is very popular use case of data, dashboard, intelligence, story, everything. eMamta and reproductive and child health portal. It's an excellent example of the nation level dashboard with a few indicators that's managed by the NHSRC. So lots of agencies combining their efforts to make it happen for the public health. So outcome, what result we get out of this? Lots of investment, lots of ministry coordination, lots of ministry effort. In last 30 years, we have managed to reduce maternal mortality rate by 83%. A huge achievement. In my days, it used to be 200 plus. And now roughly it's reduced up to 40, 30 per 1,000 mothers. And how we did it? It's tracking of each child and each mother through the dashboard. And now you are tracking each mother and each child in the whole district level, state level, and national level dashboard. So you can't, so none of the mother can escape from this net. To be able to track, if something goes wrong, we can treat her immediately. And that's how we have created effective use of digital data, technology, analytics, dashboard, and health intelligence to reduce MMR 83%. So when we use the patient data, we need to make sure about these three aspects of the patient data. You should remember that we are approaching the deadline to have a TPDA compliant hospital by June 2027. To be able to comply of the DPDA, we need to make sure that how we use and govern the data. So here is the three aspects: anonymization, data integrity, and minimization. May I ask a question? What do you mean by minimization? How do you deal with the minimization of the data? What do you understand by the use of patient data, but the aspect called as a minimization? What do you mean by minimization? Anyone from the audience?
Sir, specifically for the name, age, blood group, religion, income, family details.
No, see the description in the slide. Collecting only what is required for for treatment and care. What does it mean? Example. This is a very interesting aspect. Many of the even experts can't explain. So minimization, it means, so let's see, you are taking history of the patient with the coughing in the COVID time, okay? So you need to ask, so in a normal scenario, you would ask how many people around you actually have a coughing, isn't it? So patient goes to the doctor and the doctor asking, you have a coughing, okay, yeah. Let me have an X-ray, let me check you. breathing, take medicine, and go home. But if it's happened in the COVID time, then doctor will ask, okay, you have a coughing. How many people in your family have coughing? How many of the people in your neighbor have coughing? Okay, so this is minimization. So right now we don't need this information. But in the COVID time, we certainly have this information handy to understand what is the spread of the COVID in that particular area. So we can inform the relevant authority to go there and make sure that all people get isolated. So minimization is the context given what sort of minimum or maximum information that you can gather or can't gather. So Unit 7, we will cover telemedicine and remote care. I like this tag word, digital access beyond the geographical barrier. It's actually happening. In the remote area, if you go to the Himalayas range, Uttarakhand, Seven Sisters State in the eastern region of India, hilly area in the Jammu and Kashmir, where we need telemedicine and remote care. As I live in Mumbai, you people live in the big city, you never realize what is the importance of the telemedicine and remote care. But if you go into the eastern state, there is a 30-50 kilometers. You can't even travel. So remote care and telemedicine is emerging the way geography is the barrier. Okay, you don't need to use in Mumbai or Delhi or Chennai. But certainly if you go to the distant space in India, geographical barrier is the key to promote telemedicine and remote care. So here's the broad identification of telehealth and telemedicine. Telehealth is a kind of more broader coverage of the healthcare. And the telemedicine is very specific for diagnosis, for treatment, let's see, diabetes or hypertension. So it's a specific subset of the telemedicine consultation from the specialist. But nowadays, most of the time, you are using your mobile apps as a telemedicine tools, and it's covered under concept called as a mHealth, mobile health. Okay, so most of the time now, if you most of the sophisticated tools nowadays, it's disappearing from the telemedicine practice. Now it's only focused on the around 12 to 15 each tablet or maybe small laptops, and most of the time it's a mobile phone. So how our Indian telecare evolution has happened in last 25 years. We already reviewed this evolution in our last lecture yesterday. But right now, India has a world largest telemedicine implementation. Number of the patients, number of the doctors engaged with the telemedicine platform are huge. I think we already covered in our last lecture with the synchronous and asynchronous mode of the telemedicine modalities. If I ask you the question, if I would like to assess the height of the 10 years old children in the school, what mode should I use? Should I go for synchronous or asynchronous? I would like to assess the height and weight of the 10 years old children in the school. Should I use asynchronous or synchronous mode of telemedicine modality? Anyone? Hello?
Sir, asynchronous.
Why?
So because communication does not happen in real time. Hello? Hello?
Yeah, sorry, I was mute. Yeah. Okay, yeah, yeah. This is a very good answer, Raghav. Because you don't need a live interaction, isn't it? In able to measure the height and weight of the children, isn't it?
Yes, sir.
Yeah. So that's why. So you should be very prudent about how to utilize the different modality in the telemedicine. So this is a great example that you use all resources sensibly because we don't need a synchronous mode of telemedicine. We can just send the image with height measurement. So let's see, let me example. So you put the measurement uh, and uh, and take image of the children with the children standing on the weight machine. Okay, it's a great example. Good, excellent answer. Okay, so now let's go. The e-Sanjeevani we already covered in our last lecture yesterday. But the important you need to understand the e-Sanjeevani, it's available for the public and private sector too. Okay. So if you become a healthcare administrator somewhere in the government hospital, you always ask your CEO or your senior person that whether you are using e-Sanjeevani or not, which is available freely for the government hospital. So now it's operational in 28 states and 7 UTs. So initially they started with the 7 UTs and then expand to all the states in India. Telemedicine we already covered. What is good about the telemedicine mental health? It's it's dramatically addressed the huge gap of the mental health. And you see the 32 lakhs plus score reflected the scale of the distress, what exactly is happening at ground level. And if you are in Bangalore or surrounding area, I certainly would like you to visit this Telemanas unit in Nimhans in Bangalore. Telemedicine safely, effectively, and have a proper guideline, which is actually happened just after the first episode of the COVID in 2019. Okay. At that time, I was working in the Jaipur and that we didn't have any help from anyone. And the COVID patients were growing like anything. And that particular time, Ministry of Health and Family Welfare and Niti Aayog made it legal to consult virtual consultation in India. So within roughly just within 15 or 20 days, they come up with the legality of virtual consultation, guidelines, and so on. I would like you to refer this guideline for proper implementation of telemedicine project in your hospital and healthcare setting. So three main aspect of the guideline is identity, consent, and drug. Make sure that you understand the line below it. Liability is same as in-person consultation standard of the care. And that's how many doctors are afraid about to see patient remotely. Because sometimes if you're missing the blood result, it is missing typical information which helping you to decide on the patient care. But you see the liability is the same. Okay. Ethical and legal challenges about this telemedicine guideline. The same: data privacy, security, informed consent, equity of access, and professional liability. Someone asked the question yesterday that how we utilizing WHO digital health guidelines. Okay, so when we have adopted the digital health guideline from the WHO in last 5 years, what are the issues that come up with the Ministry of Health and Family Welfare? They have shared with us. I am also a member in the Digital Health Committees in WHO Center in Geneva, and also member of Digital Health Policy mapping in South Asia region. What we come across the one typical lapses which is happening in India or in all other developing countries, which is equity of access. See, in your slide, equity of access. So we need to make sure that the telemedicine is not available for the people who are educated, for people who know how to access, what to access, what not to access, and so on. But if you go into the remotest area where the people actually need the access and nobody helping them to get into the equity of access which is available for the all Indian citizens through the e-Sanjeevani and through the telemedicine. So as a healthcare professionals, you are working towards the health for all. Make sure that you remember that equity of access is our responsibility. We are the healthcare professionals. We are the healthcare administrator. We are the hospital managers. So we need to make sure that we remember the equity of access criteria in the digital health policy of India. Emerging technology. This is very interesting. Can I ask, what are your thought process that what sort of technologies you would like to see in next 5 years? Anybody can give answer, whatever they know, whatever they feel is important for our hospital and healthcare industry. How we can map the future smartness of the healthcare and the hospital. Just few words is okay. If you see this should happen, this should not happen, etc.
So negligence can be avoided.
Sorry?
So negligence by the doctors, by the staff, and all such thing can be avoided by the emerging technologies.
Okay, good example. So negligence is trap, is it? Okay, next. Anyone? I can see Srishti, I can see Monica P, Jenica, the yeah, anybody? Ashwini, then Pooja, Mehta, Raghav, anyone? What you would like to see, how you would like to see the smartness in the healthcare and hospital? Because you are going to lead the smartness in the healthcare, not me.
So as an example is Neuralink.
Yeah, Neuralink, yeah, that's another great example that's happening in healthcare. Okay, so now let's see, let's elaborate further in the next slide. What is possible, what must happen? So here is the great example, artificial intelligence and machine learning, which is happening in the diagnosis and the treatment, prediction, and you name it. It's everywhere. So most of the interesting area of the AI and machine learning and computer vision in the diagnosis and treatment is a area of imaging, robotics, drug discovery, predictive analytics, and so on. So, but you need to remember that in initial stage for any new technology, irrespective of what are the technology behind that, AI should support, not replace the doctor. Okay, so remember it because doctor still will be needed. So it's the concept called as a human in the loop. Okay. But right now, predictive analytics actually working for the many disease group. Let's see, heart attack, sepsis in critical care unit, and hospital resources surge in the activities during the peak time of the hospital. As a doctor, as a healthcare professional, you always remember that what are the ethical and human side of AI. So we have a data constraint in India. We have still struggling with the impact example, how exactly AI is actually contributing to the disease management, to the healthcare indicators or disease improvement, and so on. But certainly, the whole technology is actually promising to give us what we are expecting from the data, from the technology, and from the other emerging technology in the healthcare. So this is one of the great example. You can create 3D limbs, 3D fingers, 3D voice box. So it actually creates a replica of what exactly look like and what is the structure of that particular organ in your body. Though it is still in, practically it is not in industry based. It is still in the R&D research development. I have seen one application of soft robotics. When I asked them when it comes into the market, they tell it at least 3 to 5 years to make it available safely for the human use. This is a great example, IoT, Internet of Things, critical care unit, where the patient data get exported in the remote area where the specialist doctor can review patient's condition. The genomic and CRISPR, there is another technology emerging area called as precision medicine. This is another technology aspect, VR and AR. VR means virtual reality and AR means augmented reality in training. Most of the medical training is, lengthy, very complex, very resource intensive. You need 30 to 50 faculty to run the medical college, to train the doctors. But the emergence of this new technology actually helping you to learn faster, learn effectively for the larger number of the students. So in the metaverse, it's very interesting metaverse. So lots of people can view one complex surgery together. It's even it goes in a million. So one doctor I know in the UK, they perform the surgery and it can get webcasted live in the Facebook. So in the Facebook and event, you can view the actual surgery happen. So this is how we can create the scale. So this recent news that happened maybe just a week ago, that a surgeon from Hyderabad went to the China, the area called as Wuhan, and he performed the urological surgery, means surgery on the urology system in the patient body, and patient was in Hyderabad. So they used the metaverse, they used the 3D technology, they used the 5G technology, and they used the robotic surgeon. So robots sitting in Wuhan, and the second robot is sitting in the Hyderabad on the top of the patient. And the surgeon can operate from the China itself. This is another data-driven technology available for the hospital industry. Digital twins for diagnosis and personalized care. There are three key areas where digital twin has a successful use case. One is simulate progression, assisting diagnostic, and the personalized care. Now, in the unit time, we'll talk about designing healthcare apps. As a healthcare and hospital manager, you won't directly involve in the hospital and healthcare application, but if you know that how it works, what are the steps they follow, you possibly can contribute more towards it. So you need to identify digital health ecosystem, who are the stakeholders, and what are the data resources for to creating the hospital apps. You need to understand this SDLC model in healthcare. SDLC means software development life cycle. So in healthcare, we're using three model of SDLC, software development life cycle. First is the waterfall, second is agile, and third is the V model. You don't need to understand, or you don't need to go deep inside this concept, but you know that waterfall is the part of the SDLC process. So these are the 7 steps of the SDLC, software development life cycle. So it starts with the first, you see in the top of your slide, planning, and it's end with the maintenance of this application. While if you are helping the technology to design the software, you use design thinking stages to make it user-centered application. So let's see if you are working with the ASHA worker, okay? So you need to make sure that it can be usable by ASHA worker. So once again, we reviewed this in our last lecture. DPDA, we also reviewed it in our last lecture. Future outlook. To achieve universal health coverage, we have a BTM, we have a AI technology, and e-Sanjeevani. Make sure you have a effectively utilize all those resources to make universal health coverage happen in India. This is the stakeholder list. We already saw in our lecturing yesterday, but now you see the patient, the technology service provider, and the health service provider are the main stakeholder of all our unified healthcare system. So this is the stakeholder map if you are to participate and design the healthcare application for your hospital or for your state or central government. Make sure that when you're dealing with your day-to-day hospital operation, you understand this. These are the different digitization, digitalization, and the digital transformation. So it starts with the digitization. So most of the time, what you do, whatever you see the paperwork, you try to make it digital. Okay, so that is called as a digitization. If you go to the next level, you have a cloud application, you have a data application, you have a other technology helping you to make process faster and efficient. That is called as a digitalization. But what are the digital transformations? So you are natively put all the digital tools, not to use any other technology. Okay, so each and every process you plan is digital. So you don't have to worry about the digitization and digitization of it. Okay, so digital transformation is make everything digital, end to end. Now we are nearly approaching end of this day, and I'm ready to take any question from this. From the audience, sorry. Yeah, please. So we have 30 minutes for question and answer. And I also would like you to see all the references given in your module. I saw lots of resources are given in the end of this module. I would like you to review it. Just have a glance of it. You don't need to go inside and to just have a detailed information, but just go through whenever you get the time. Any questions from audience? Anything? So let me start with the Dr. Raghav, and then I'll go one by one.
Hello.
Yeah.
Sir,
Any questions from this module? Yeah.
sir, what are the risk of over dependence on healthcare IT system?
You, you mean end-to-end digital transformation, is it?
Sir, we are depending most of the time on the IT system right now. So what are the risks if we fully go digital right now?
Yeah, two risk is very much visible for everyone. Let's say you lost internet connectivity. Okay, all gone. Very second day. So someone has just cut the fiber near the hospital. Okay, you lost the connection to the cloud. The second is the cyber security, because you are now exposed to the internet with your data, with your application, with your server. So cyber security is a huge risk. Or someone is asking for
Yes,
ransom.
sir.
Okay, we store your data.
There is a recent attack on AIMS also in 2020 or 23. AIMS
Yeah,
website.
yeah. They asked. I think they asked for 500 crore. They steal the data of roughly 12 years of the total data. They kind of ask for the ransomware. They attack with the ransomware and block all the access of the cloud resources. Yeah. So cybersecurity and to access live access of the data in case of internet, it's not available at that particular moment. Anyone else from audience? So let me go with the next Srishti Gupta. Yes, madam. Any question?
No, sir.
Okay, thank you. Next, I can see Rakesh Kumar. Rakesh Kumar Verma. Yeah, Rakesh Kumar Verma, any question in this blog?
No question, sir. Sorry, sir.
Sorry?
Sorry, no any question.
Okay, no issue. Okay, what we have now? Anyone else? So now we have 3 people left. Okay, no issue at all. Okay. Now, should we end this session? I think we have covered everything with a reasonable amount and depth.
Sure, sir.
And do you need to take post-lecture questionnaire? So if you can ask your administrator to serve you, or maybe give you the link of the questionnaire. Okay, I hope that you like the delivery and you understand the very basic concept of this block. Thank you once again, everyone. And we will meet tomorrow sharp at 5 p.m. for our upcoming third block of this module. Thank you very much,
Thank you, sir.
everyone.